Okay. First of all, I would thank Dr. Osama Hussein for this chance and this very prestigious scientific committee. He gave me a very good chance to introduce this case scenario as an introduction to one of the most eminent neonatologists, Professor Alauddin Radash. It's a great honor for me. Our case scenario today is a very simple case. It is straightforward. No tricky parts. It's very simple, and we are facing this scenario every day. I don't think so that any neonatologist have even one day in the NICU can solve this case scenario. But the aim of this case scenario is to order a mode of thinking, how to think and how to think in order and in correct way, and how to manage in the correct time. This is the aim of the scenario, but it's not tricky. It's very easy. So I hope you will enjoy this case. We have day 0. We have a preterm male infant, 32 gestational age. His weight is 1.8 kilogram, admitted at NICU due to respiratory distress syndrome. He was born to a primigravida mother who had preeclamptic toxemia. Premature rupture of membrane occurred 8 hours prior to delivery. No signs of maternal infection. So to summarize, we have a preterm born to a primigravida mother, irrelevant any problems during pregnancy or delivery, apart from premature rupture of membrane 8 hours before delivery. So when we examine the baby, he showed desaturation with respiratory distress grade 2. Surfactant was given by Ensure technique and put on nasal CPAP. An UVC was inserted. Initial lab showed total leukocytic count 12, neutrophil 60%, hemoglobin 14, platelet 490, and CRP is negative. To summarize, preterm with respiratory distress, received Cervanta. Everything is smooth. He is not intubated. He is not on mechanical ventilation, just on nasal CPAP. So we have first question: start antibiotics or not? Someone will answer, I have CRP negative, baby is well, why I start? And this is not the mode of thinking we'd like. This slide is very important for everyone I want everyone watching us to have a screenshot of this slide. It's very important to be in our cell phone all the time. We have 3 blocks or 3 categories. Red flag: if any one of these 6 red flags present, you will start antibiotics. Any 2 of the risk factor or clinical indicator, you will start antibiotics. So we have a preterm following spontaneous labor with respiratory distress. We have 2, so we will start antibiotics. We started antibiotics. Baby on day 5. Culture showed no growth. CRP is negative. Baby is well. So we have a baby after 5 days of antibiotics. We reassess again, and the baby is well, no growth of culture, and CRP is negative. He's doing well, feeling is upgrading. To stop or not? This question is very important. في حد ممكن يقول خلينا prophylaxis، حد يقول no, the baby is well, no use for antibiotics. Guidelines say if we start antibiotic, you should review the antibiotic you start 36 hours after your start, as initial clinical suspicion of infection was not strong. With negative blood culture, and the baby is well, with no clinical indicators. Baby is well with no clinical indicators of possible infection, with CRP trends are reassuring, so we will stop antibiotics. So this baby, antibiotics are stopped. At this moment, the baby is hemodynamic stable on nasal CPAP. Feeding is upgrade. Again, we are on the 5th day. Okay, day 7 of age, after 2 days of stoppage of our antibiotics, the baby showed lethargy, evolving respiratory distress with frequent apneas, cold extremities, weak peripheral pulsation, capillary fill time for second, which is prolonged. EPG showed mixed metabolic and respiratory acidosis. Baby mechanically ventilated, and received IV shock therapy with inotropes. To summarize, baby was previously well, doing very well after stopping of antibiotics with 2 days. At the 7th day, our preterm baby showed picture of shock and respiratory distress. So question number 3, what's the differential diagnosis for this deterioration? It is the second slide. I want every neonatologist hearing us today to screenshot this slide and preserve it on his or her cell phone all the time. The 5 differential diagnosis of deterioration of previously stable preterm baby. It's late onset sepsis or necrotizing enterocolitis or one of the ear leak syndromes or hemodynamic significant TBA or IVH. You will screen for every single of these 5 differential diagnoses. So for our baby chest X-ray, proven no evidence of ear leak syndrome, echo study, no evidence of BDA, cranial ultrasound, no evidence of intraventricular hemorrhage. Necrotizing enterocolitis is less likely in the context of normal abdominal imaging and absence of GI symptom. So we have only sepsis. Another blood culture and septic marker was drawn with this results. CBC total oxide count 20 and neutrophil 80%, platelet 50, hemoglobin 12, and CRP 48. There is also toxic granulation in neutrophils. Blood culture, of course, is pending. Lumbar puncture is cancelled as the baby is hemodynamic significant and has thrombocytopenia. So we are facing a common presentation of case of late onset sepsis, but of mode of thinking how to reach this diagnosis and execute the other is the important point of view. Which antibiotic to start? Guidelines say to start vancomycin and gentamicin, the agreement of NICE guidelines and the American guidelines. At day 12 with antibiotics, blood culture showed growth of negative staphylococci, which is a very common organism incriminated in late onset sepsis with sensitivity to vancomycin. So we will stop gentamicin. Baby is extubated and shifted to nasal CPAP. Inotropes also stopped due to hemodynamic improvement. So our baby is so stable after this 5 days of antibiotic shift. So when to stop? Guidelines say we can stop this antibiotics after about 7 to 10 days. So at day 15, we stop antibiotics. Baby now is vancomycin is stopped. Baby is off respiratory support. Has full of oral feeding. Trial for breastfeeding is successful. So baby is discharged home. Our mission is done and referred for visual and hearing assessment. This is the case. Before I end, I want this gold rule to be in the mind of everyone. The art of neonatology lies in anticipation. It's not our mission to treat preterm babies or newborn babies in NICUs. It's to anticipate the problems that can occur and take a step behind our baby. There is a common thing we can example that can we mention. If our baby receiving surfactant therapy due to respiratory stress syndrome, if you don't anticipating ear leak syndrome, your baby will go on pneumothorax or any ear leak syndrome. So you give surfactant, anticipating this surfactant will improve the lung compliance, will affect the pressure needed and time constant needed. So you will change your parameters, anticipating the child to have ear leak syndrome. So your baby will not have pneumothorax. You protect your baby by just anticipation. Our case always anticipation for sepsis. We have a preterm. We should anticipate that our baby can develop sepsis, so we can apply every step and very strict steps of infection control, so we can anticipate sepsis, so can we prevent it. So art of neonatology lies in anticipation, and thank you.
Okay.